Hi, I'm Dr. Andrew Alexis, board certified dermatologist from New York City, and it's my pleasure to be joined by a good colleague named Dr. Erik Domingues, and I'm going to let Erik introduce himself. Erik?
Hi, I'm Dr. Erik Domingues. I'm a board-certified dermatologist. I'm assistant professor of dermatology at UMass Chan Medical School and also in private practice at Modern Dermatology of Massachusetts in Fall River, Massachusetts. So happy to be here with you today, Andrew. Thank you.
Pleasure. So, Erik, I know that you have a great deal of experience with vitiligo, and you've seen the evolution of vitiligo care over the past 10 years. In fact, probably should call it revolution in care. What do you think are some of the biggest changes in the overall approach to vitiligo today compared to just a few years ago?
Yeah, it really has been amazing what's happened over the last few years. You've just seen this shift in treatment paradigms where before, patients came in and we didn't have many options for them. They would try the topical steroids, try some topical calcineurin inhibitors, but now we actually have options that we can provide for our patients. And instead of them just ignoring their disease, which they've dealt with sometimes for many years or decades, we finally have treatments that we can have a good discussion about with our patients when they come in to see us with vitiligo, or if they come in for something else, right? They're coming in for a skin cancer screening, you notice vitiligo and you bring it up and just have a good discussion with them.
Yeah, that exact scenario does come up in my practice as well. They're coming in for a different reason, and then incidentally, you identify these depigmented patches. Sometimes when I've done that, it's in a patient, particularly a patient who's perhaps over the age of 60, has had the white patches of vitiligo for many years and is sort of adjusted to having them, and their skin type might be a lighter skin phototype, so the patches aren't as obvious. In that particular scenario, I found myself having a little bit of a back and forth with the patient, where the patient's maybe not even that excited about discussing treatment options. Have you ever had that, Erik?
Oh, absolutely. Or sometimes they said, "Oh, I thought that was just part of my normal skin." They've had it for such a long time they didn't even realize that they had vitiligo. Or yes, to your point, they say, "Oh yeah, I've had it. I don't really notice a difference." Or they'll say, "Oh, I only notice it during the summertime." Right? They get a little bit of color on their regularly pigmented skin, and then they notice it. But then the rest of the year, especially if you live in a colder climate like I do up here in New England, for most of the year, they're not really noticing much of a difference in those lighter skin patients.
Right. So I think that's like one end of the spectrum. And then we go to the other end of the spectrum, which I know both you and I see a lot, where you have those patients who are really devastated by the presence of their vitiligo and are seeking out our expertise and looking for recommendations. Can you tell us about how you manage those patients?
Well, so those I like to always just tell them, I'm here to help you, right? We're on the same team. I treat vitiligo. I enjoy treating vitiligo. And I tell them, we have options now that we never had previously. I like to always go over, what have you tried? How long have you had your vitiligo? What bothers you? How does it make you feel? I think one of the things that sometimes we forget about vitiligo is that it's not only a skin-only condition, right? Our patients sometimes are deeply impacted by this, where it's really causing other, psychological issues, emotional issues, and obviously they can have other associated comorbidities. Obviously, we have the thyroid disease and other autoimmune conditions, since vitiligo is a chronic autoimmune condition. And I think just having that discussion with our patients and really just letting them know that we're there to assist them, to really guide them, and to be in their corner, right? In the end, I'm a really big fan of shared decision making, which I found really has been helpful, because we can really make some suggestions for treatment. But if the patient doesn't want to treat, or if they're not motivated, we need to basically let them know that we are there to help them. I think if we do that, certainly can lead to better treatment success. What have you found that works in that case for those patients as well, when they come in and they're very distraught by their vitiligo?
Yeah, I completely agree with your approach, including listening first and then shared decision making, and really getting insights into how it's impacting them overall, and then getting into treatment options that would align with what they're looking for. But of course, before we even talk about treatment options, we've got to establish the diagnosis. So why don't we dive a little deeper into, well, how do we arrive at the diagnosis in the first place? Do you use the Woods light? Do you not use the Woods light? What other approaches do you take when faced with that patient who's got loss of pigment in macules or patches somewhere on the body?
I think the first thing I think we have to do, obviously, make sure you have the patient in a dark room, right? I always have a Woods lamp available. My staff knows if the patient comes in complaining of potential vitiligo, we get them in a dark room, we get them undressed, get them into a gown, and of course use a Woods lamp. And many times you're going to find areas of vitiligo that the patient never even knew they had. They might come in just complaining of their hands or their feet or their face, and when you get them undressed, they can really be quite amazed at how depigmented they actually really are. Have you ever found? I have personally not found a biopsy to be necessary, but do you ever biopsy for vitiligo? I've only really found it more, in my experience, helpful for ruling out other conditions. But have you biopsied for vitiligo yourself?
Yeah, great question. I completely agree with you. I don't think a biopsy is part of the routine management as far as diagnosis, but there are certain scenarios where we're trying to rule out other diagnoses, as you just said. I can think of a recent case where I had a patient with depigmented patches in her scalp. And when you see that, you wonder, were these discoid lupus? Were these areas discoid lupus that have now resulted in depigmentation, which would be one potential diagnosis that could lead to depigmented patches in the scalp. So while vitiligo was my primary diagnosis using the Woods light and not seeing any other aspects of discoid lupus, no follicular plugging, atrophy, etc., I still wanted to just be sure because it was a little bit unusual that it was only on her scalp. So I did a biopsy and ruled out that there was nothing else going on, and it was consistent with vitiligo, and she's been treated accordingly.
Yeah, that's precisely what I do as well. Is if I'm thinking it could be something else, scleroderma, even lichen sclerosis, right? Sometimes that can be also another disease state that we may see that may look like vitiligo. But I think for our colleagues out there, I think really distinguishing between depigmented versus hypopigmented is key. Right, that's obviously where I think the Woods lamp certainly helps. What have you found in your clinical practice that has been helpful when you distinguish, I guess, helping our colleagues here to distinguish between depigmented and hypopigmented lesions that are not consistent with vitiligo?
Yeah, so I also depend on the Woods light to differ. That's my first question. Are these light patches that we're being presented with, are they depigmented or are they hypopigmented? And it's the Woods light that helps me differentiate that. How? Of course, on the Woods light, in depigmented, we'll see this milk white sort of appearance, so an absence of pigment, and that confirms that it's depigmented. But if that's not what we're seeing, then we start thinking about hypopigmentation. If it's on the face involving the medial cheeks, palpebral area, we might think about hypopigmented seborrheic dermatitis or post-inflammatory hypopigmentation associated with seborrheic dermatitis. If it is on a different location, we might see post-inflammatory hypopigmentation from other inflammatory disease states like psoriasis or atopic dermatitis, etc. So yeah, that's kind of how I approach it. You mentioned scleroderma. That's such a good one because as far as differentiating, because that can be tricky sometimes. You see that salt and pepper dyspigmentation of scleroderma often on the upper trunk, and it can be confused with vitiligo with some follicular repigmentation, but it's not. It's scleroderma. So palpation is really key. Feel for that induration. Look elsewhere, like the digits, to look for any sclerodactyly and the nail folds, proximal nail folds for telangiectasias, etc. And taking a detailed history is all important to differentiate.
This really, goes to show, in our discussion here, how usefully Woods lamp is, right? I had a patient present the other day for hyperpigmentation around the mouth. Well, I said, okay, let's grab the Woods lamp. Well, I brought out the Woods lamp. It appeared to be hyperpigmented because she had perioral vitiligo, right? So around the mouth was depigmented, and then her normal skin was what she thought was being actually hyperpigmented. And of course, that was a diagnosis that patient was not even considering. She just came in for darkening around the mouth. And when we brought out the Woods lamp, diagnosis made. So definitely an easy diagnosis to make in many cases. Other times, of course, yes, the biopsy certainly can be helpful when we're distinguishing between vitiligo and other conditions. And it certainly, you've seen this probably as well many times, the associated comorbidities in our patients with vitiligo. I think it's important to certainly do a thorough physical exam, review of systems, but what specifically do you ask your patients when you're looking for other comorbidities that may be associated with their vitiligo, such as thyroid disease, as an example?
Mm-hmm. I'll start with a history, taking a history of any known comorbid conditions, autoimmune conditions that we know can be associated. But in the absence of any known documented conditions, I'll routinely check TSH, CBC. I don't do in the absence of anything in the history that would point to a specific condition, my workup is quite limited to a CBC and TSH. Do you do anything else, Erik?
No, not really that often. I will say I checked an ANA recently in a patient with vitiligo because of a family history of lupus. But ANA is one of those that I don't really check often either, unless again their history, physical exam warrants such a test. But really, the thyroid disease is the one that, in my experience, almost half of my patients come back. Well, a lot of them already have thyroid disease when they come in and present with vitiligo. But I will check again thyroid, as you said, CBC for pernicious anemia, even blood sugars. I don't really check those either for type 1 or type 2 diabetes. We have a really robust primary care network here in our community, and our patients are really well plugged in. But I think if a patient doesn't have a primary care doctor, you could consider checking, obviously, a fasting serum glucose as well. But other than that, just like you, very limited. I have found that really not fruitful in finding other conditions if their physical exam and their history does not warrant it.
Yeah, you bring up a very good point about hemoglobin A1C, and thinking back to how do I routinely do it? I do actually lead with making sure they're plugged in with a primary care physician, knowing that these very tests are part of the routine screening in primary care: CBC, TSH, hemoglobin A1C. So I know that at least they're getting that done annually.
And what about, we hear about patients with vitiligo having hearing impairment, sensory neural hearing loss. Do you see that often in your vitiligo patients? Because we read about it, but I haven't really seen too much of that over the years.
Not.
Yeah, and I don't recommend regular audiologic assessments to look for that either. But I've read that there's definitely a risk there, in patients with vitiligo. I just never really seen it, over the years. And how do you discuss risk of passing this to your children, right? Patients always ask, I have vitiligo. Are my kids going to get this? How do you approach that question? Because it definitely comes up quite often in adults who have children, obviously, who then have vitiligo as well, the adults.
Yeah, it is indeed a common concern, especially in some cultures, right, where depigmentation has additional stigmatization culturally. So the answer isn't a straight answer. Of course, this is I kind of explain in as everyday English as I can that it's a genetically complex disorder, that there are genetic factors and also environmental factors, and having vitiligo yourself doesn't necessarily mean that your kids will definitely have vitiligo. But yes, there is a higher risk. I'll often mention that there are even scenarios with identical twins where one has vitiligo and the other doesn't. Would you agree with that, Erik?
Absolutely. Always. I actually have seen that where, one twin does, one twin doesn't. But I've also seen the case where both twins have it, right? You see both sides of the spectrum. And I just always tell them, one of my mentors, John Harris, always said, 6% chance of passing it on to your kids. Do I see 6% of the time? No. Sometimes I feel like it's higher. Sometimes I feel like it's much lower. I think it really depends on the time. But certainly an interesting question that I think we can't really give a straightforward, this is how it's always going to be kind of answer for our patients.
So why don't we talk about management? So once we've got the diagnosis and we've taken a detailed history, thought about comorbidities, et cetera, what do we do to actually treat the vitiligo?
So I know what I like to do to initially start is, do they want to treat, right? Some patients are very adamant, doc, I've had this for 50 years. Doesn't bother me. I don't want to do anything. But I always make it a point that if I have someone coming in with vitiligo, whether they came in for vitiligo or came in for something unrelated, I like to let them know, you have vitiligo. There are things that we can do to treat this, because there's always that mentality. Obviously, you've seen this in your career as well, Andrew, over the years, where patients have been told by many clinicians, there's nothing to do for your vitiligo. And I think we really have to get out of that mindset and really talk to our patients and let them know that we do have treatments that can be effective for repigmentation of their vitiligo. Do you agree?
Yeah, completely.
Yeah.
And in fact, my tone in describing these the management options in 2025 is a lot more upbeat and enthusiastic than it might have been historically, because not only do we now have our first ever approved therapy for repigmentation of vitiligo in ruxolitinib 1.5% cream. So of course, discussing the risks and benefits of that therapy with my patients, but also giving them a sense of hope that there actually is a pipeline, and it's quite likely that we're going to have even more therapies in the very near future. And so it's sort of taking that patient from often feeling hopeless. Oh, there's nothing that can be done. I went to other doctors. They said there was nothing to do. To no, actually, there is something we can do, and we have things available right now, and we may very likely have things in the very near future that in addition.
I totally echo that. The upbeat discussion that we have now, I think about years ago when I was a resident, and we really were very limited with our options. And it was frustrating because as doctors, we want to help our patients. And these patients are frustrated. Some of them, again, like you said, feel hopeless. And I've seen patients get depressed from their vitiligo. And, mental health becomes a big discussion that we have as well with our patients. I've had patients who, like, doc, like, I am desperate. I don't want to, participate in social activities. I'm embarrassed to go to work. I'm embarrassed to hang out with friends, this or that. And it really can be quite detrimental. And as you know, obviously as well, it can also be a big cultural issue. There are some cultures there where depigmentation, vitiligo, can be quite stigmatizing to these patients. And I've heard those stories as well in the community where I practice. And I really, again, now have this discussion with them, which is just so much better. And, it's, again, to your point, everything we have in the pipeline, we have oral JAK inhibitors that are going to be coming out in the next several years, approved for vitiligo. That's going to be exciting as well. And, there are other interleukin-15 inhibitors that we're talking about. So definitely something that has been very exciting for us and for our patients. So when a patient first comes in with vitiligo, what do you first like to talk to them about when it comes to treatment? They decided that obviously they want to treat their vitiligo. They haven't used anything. How do you approach those patients?
Yeah, so the first assessment is to figure out, can I treat this patient with topical therapy alone, or am I going to need topical therapy plus something else, such as phototherapy? And it's largely dependent on body surface area. Actually, over 10%, of course, I'd start to think about phototherapy and other approaches. But so everyone is getting topical therapy, but the question is, are they getting topical alone or topical plus phototherapy? And for areas that are, limited under 10%, that's someone that might do okay with topical therapy alone. My leading topical therapy would be ruxolitinib 1.5% cream twice a day. And I set expectations right from the beginning that this is going to be a slow and steady process, and I demonstrate to them, what does success look like? When I describe like the little brown dots of pigmentation that we're looking for, and when we see that, we're going to get very excited. And that might be all we see at the next follow-up visit. But if we stick with the therapy, we can get more and more of those little pigmented dots and fill in the larger white patches. And I'll show them pictures of that. I love this data from ruxolitinib 1.5% cream, the longer term data that we now have with 2 years of therapy, not only demonstrating the safety, but also showing individuals who had a lower response at the 6-month mark, but then went on to getting a FAAD 75 response at the 2-year mark. And I think that really helps encourage patients to stay on treatment so that you can get the return on your investment.
Yeah, that's precisely, what I do as well. It's, coaching our patients. It's all about setting expectations, right? There needs to have that mindset that vitiligo is a totally different disease state from atopic dermatitis or psoriasis. I always like to explain that your body needs time to shut down that inflammation, and those pigment producing cells need time to basically get back to work. I describe it as like a factory, right? The factory's been shut down, the computers are off, lights are off, all the inflammation's there. Once the inflammation's gone, you need time to turn the lights back on, open the doors, get the computers back up and running, and then your pigment producing cells can finally start to produce that pigment. And patients really like that description because it kind of just makes it easier for them to think about that. And yes, as you described the brown dots, I call them polka dots with my patients. I see a lot of adolescents, so the polka dots really go a long way. And photos, photos are tremendously important. We take a lot of photos at baseline, photos at every visit, and we look for any sort of sign of repigmentation. That certainly keeps our patients motivated. And I tell them, this is a marathon, not a sprint. This, you could repigment in 3 months, you could repigment in a year. I've had patients who repigment in 3 months and they're thrilled, but I never promised them that. And then you have others, 12, 15 months. And again, that 2-year data really has been tremendously helpful because it really supports what we already see in clinical practice for our patients. How do you approach the more complex patient, the patient that's rapidly depigmenting, the one that has the 10 fingertip involvement or the Kebnerization and confetti-like macules? I like to use dexamethasone. What is your regimen for that, for those types of patients?
Yeah, I agree. So we're talking about unstable vitiligo, and you mentioned some of the clinical signs of unstable vitiligo, including confetti or Kebner or trichrome vitiligo. And so if I see something like that, any of those signs, or literally see rapidly progressing vitiligo by history, the patient saying, "Oh, I've been developing more and more patches just in the past 2 months or so," I'm going to want to sort of arrest this rapid progression using, just as you said, dexamethasone pulse dosing. I do 4 milligrams Saturday and Sunday for 6 weeks. That's my my approach. How about yours?
So I've done anywhere from 2 to 4 milligrams Saturdays and Sundays, up to 3 to 6 months, depending on the patient. But usually 12 weeks is the most that I've done. But at the same time, of course, overlapping with topicals. Certainly, that's always something we want to continue on those patients. Some patients want to do it, some don't. There's a lot of fear, of course, of steroids from patients. So some patients just really don't want to do it. Others, of course, are motivated to do so. So again, shared decision making, getting the patient's input, and going from there.
I'll just add that in this scenario, I'll also consider, depending on how widespread it is, narrowband UVB as well on top of that, if the patient can do that 2 to 3 times a week.
Yeah, narrowband UVB is certainly one of those oldies but goodies. One of the limiting factors in our community is just the lack of resources, right? And not everyone has phototherapy. We don't in our clinic just because of spacing. The closest clinic is about 20 minutes away. So patients who want to do it, certainly it's a great option. Still, one of the safest options out there as well. Do you find that patients push back a lot on phototherapy, or are they motivated to use phototherapy, 2 to 3 times a week?
Yeah, it really depends on the patient. There's so many individual factors, the distance between our phototherapy unit and where they live, and what's it going to take for them to come in 2 to 3 times a week. For some, it's reasonable. For others, it's not. Then comes at-home units. We'll sometimes use that for those that where the barrier is just the distance or cost of coming in, and some of my patients will invest in a home unit. So yeah, it's not for everyone, but for those that can do it, it's a great addition when needed, particularly when you have more widespread disease, or if topical therapy alone is not producing improvements at the rate that the patient would like, and adding phototherapy can accelerate the response.
Right. We've talked about using topical ruxolitinib for our patients with more limited skin disease. But how do you deal with patients who have not tried any treatments and now have to try maybe a topical steroid first? TCI, and how do you explain to them, limitations in certain, treating certain body areas? Because obviously we've all had the patient who ends up putting clobetasol on their eyelids, right? Despite us educating them and us cringing at the thought of that being done. How do you approach that, educational piece when you're first treating these patients who have not tried anything previously?
Hmm. So particularly in the pre-ruxolitinib era, and even still today in scenarios where there's access issues or just sometimes quantity issues where it's just not feasible to spread the ruxolitinib to cream to all the areas that the patient has. So this is where topical calcineurin inhibitors, specifically tacrolimus for me, tacrolimus 0.1% ointment, comes in a 100-gram tube. So you got a little bit more area to cover. And with respect to corticosteroids, depending on the anatomic location, if it's the hands, okay, I'm going to use clobetasol there. I'll do 2 weeks on, 2 weeks off of a good, strong, super potent corticosteroid, 2 weeks on, 2 weeks off, alternating with the non-corticosteroid TCI or topical ruxolitinib if that's what I'm using. But that's not to say that I wouldn't use topical ruxolitinib alone in that scenario. But if it's a scenario where I feel the need for addition of corticosteroid, I'll do a 2 weeks on, 2 weeks off approach. For the places where you don't put corticosteroids, such as the eyelids and other parts of the face and the intertriginous areas, I'll very clearly indicate to the patient that we've got steroid and non-steroid, and this is what you're putting in this particular location. I'll definitely put those directions into the SIG of the prescription. Now, I never just put as directed to affected areas. I have to put the actual, spell it out, the anatomic areas. I make a point of doing that, and even write it down separately as a separate guide, a takeaway from the office, like an after visit summary, or even a handwritten note that says, "Here's what you're using at this location, and what you're using in another."
I remember when I was a resident, I was treating someone's vitiligo with clobetasol. So our regimen was, clobetasol every day, twice a day, 1 week on, 1 week off. The week off was tacrolimus, and then for sensitive areas, only tacrolimus. Again, this is pre-ruxolitinib era. I had a patient who actually developed quite extensive striae and atrophy from clobetasol on their torso, interestingly, with every other week dosing. And that always was kind of an impactful thing that to this day, probably almost 20 years later, I still think about that and think, wow. So it's one of those things where obviously it's not going to happen often, but now in the ruxolitinib area, my goal is to bridge you until I can get you to ruxolitinib. I want to prescribe ruxolitinib right off the bat, but if there again is an access issue, insurance issue, whatever it may be, some sort of requirement, because most patients have to try at least one topical before they can get ruxolitinib. I'm just bridging them over till I can get them onto ruxolitinib twice a day, as that's what has become my standard of care now for my vitiligo patients. So Andrew, obviously one of the things with JAK inhibitors used for inflammatory conditions is the boxed warning that's been given to all JAK inhibitors with use in inflammatory conditions. How do you approach that discussion in our patients who you're going to treat with ruxolitinib?
Yeah, great question. Of course, that's a scenario we face almost every day when you prescribe the topical JAK inhibitor ruxolitinib. If you don't explain to the patient in advance, they might go to the pharmacy or come home and then see the black box warning and then have a lot of concerns. So I want to discuss that head on and mention that there is this warning, and I give them some context as to where it came from. I describe a different patient population with a different condition using a different JAK inhibitor that was oral in a patient with risk factors for cardiovascular disease and on another immunosuppressive medicine, methotrexate, etc., describing the tofacitinib basically study that led to the black box and differentiating that from the safety data that we know from topical 1.5% ruxolitinib cream. And so when you put it into that context, I find that then patients are comfortable.
Yeah, I agree, and I don't check any labs on ruxolitinib. I think if you keep it under your 10% or lower BSA, you're fine. That's how I explain it to patients. And I explain that 1% is one handprint. I think that's important because patients, of course, have no idea what a BSA percentage is until we educate them.
So, Erik, I primarily treat adult patients because we've got 4 pediatric dermatologists here. But and for most of my career, I've had extraordinary pediatric dermatologists with me, including some with interest in vitiligo. So I'd love to hear your experience with adolescents and pediatrics. Any nuances there?
I think the important thing is getting the parents involved, getting the patient engaged, right? I always look at my patients in the eye. I don't care how young they are. They could be 12, they could be 16. I don't look at the parent, I look at the patient because I want to see how they're reacting to what I'm saying and what I'm talking about. I see a lot of adolescents with vitiligo, and it can be quite distressing because certainly these are the formative years. They're teenagers, they might get picked on, there might be some bullying, which is very unfortunate. And our goal is really to let them know that we're there to help them. And I like to show them a lot of photos. Photos are tremendously important. All these teenagers have cell phones. We take photos of their vitiligo with their cell phone as an example, also with our clinic camera as well for our documentation. And then we see them regularly for follow-up. I will start them on ruxolitinib, 1.5% cream, BID, bring them back frequently for follow-up. I bring them back after a month, not because I'm expecting repigmentation, but just to make sure that we're still keeping them motivated and I can still coach them through this. And I say, this is, again, a marathon, not a sprint. I have one patient that I can think of that for the first several months really wasn't using ruxolitinib consistently. And once we talked about, twice a day, every single visit. And I showed her photos. When she finally saw a little bit of change, that motivated her. And when she started using it consistently, everything started repigmenting. And that coaching in these adolescents and teenagers certainly could be quite impactful. And of course, having the parents also be very supportive. That's obviously a very important point to make, because without that support at home, sometimes teenagers and adolescents can lose some of that motivation in treating their vitiligo.
Yeah, great. Thank you, Erik. Just circling back to our conversation about corticosteroids, I wanted to add that, we talked about clobetasol in areas like the hands or the feet, 2 weeks on or 1 week on and off. We both have our different approaches to that. But in areas where you wouldn't want to use clobetasol, but you still want to use a corticosteroid, for me, mometasone is something I'll use. I'm comfortable using mometasone cream 2 weeks on, 2 weeks off, even on the face, not the eyelids, but elsewhere on the face, alternating with a topical calcineurin inhibitor if I'm doing that kind of corticosteroid TCI approach. How about you?
Oh no, I have not used topical steroids in the face, not intentionally, right? Patients, of course, have done it on their own. Here, my goal is always just to bridge them over to ruxolitinib. In the past, I probably would have done that, but now my goal is, as quickly as we can, let's get you onto topical ruxolitinib. I have found that areas, of course, as you know, with higher follicular density will repigment the quickest. The face is one of those areas where, in my experience, just repigments quite well for most of my patients. Luckily, hands and feet, of course, are always going to be a little bit tougher, but the face is one of those more reliable areas. What's most exciting to you about what's in the pipeline? What are you looking forward to? We have interleukin inhibitors, we have JAK inhibitors. What most excites you for your patients?
Yeah, taking a peek into the future, I think that now that we've got this new advance in topical therapy, when it comes to patients who have more extensive disease, the ability to be able to treat them with an oral agent, I think is going to be I'm looking forward to hopefully having oral agents in the near future, specifically oral JAK inhibitors. And so we've got several that are in the pipeline: povorcitinib, upadacitinib, and others. And yeah, I'm excited about that space.
Yeah, it's a very exciting time to be a vitiligo patient finally for the first time, in many years. For the last few, we finally have things to be excited about for our patients where we can finally help them. We've had it's been a great discussion, Andrew. I really enjoyed talking to you about vitiligo and our approach to treatment. We've talked about some pearls, treatment, diagnostic. Any other pearls for our listeners that, you'd like to offer that we haven't maybe discussed already or just want to touch upon again before we wrap up?
Well, I guess I would just also reiterate, it's been great discussing vitiligo with you, Erik. You've got a ton of experience, and it's nice to compare notes on our varying approaches to treating patients. But I completely agree with you on the value of getting patients on topical, the topical JAK inhibitor, 1.5% ruxolitinib, but we also sometimes have to turn to our old school therapies for access reasons, as you said. But I'm excited about the future with newer oral therapies that are coming down the pike.
Yeah, certainly an exciting time for us clinicians and our deserving patients with vitiligo. Thank you.